For over a century, the theory of muscle knots or trigger points has been a widely accepted fundamental belief in healthcare. But what if I told you that some experts have been debating this concept for decades, considering it more of a medical myth than a reality? A concept that forms the very foundation of so many treatments for pain and injury, from myofascial release, compression, and massage to electrotherapy and dry needling, a concept that is trusted and promoted by health professionals worldwide. And based on my experience as a practicing physiotherapist, the use of some form of trigger point therapy appears almost universal. In fact, a 2019 study showed that over half of American physical therapists incorporate dry needling into their daily practice. Still, the role of trigger points in musculoskeletal pain remains questioned.
A knot is like a unicorn. We can all describe it, but that doesn't make it real.
As clinical trials and observations cast doubt on their diagnostic reliability. This not only challenges our understanding of these practices, but also calls for a comprehensive re-evaluation of how we approach pain and injury rehabilitation. If the existence of trigger points is shrouded in uncertainty, how can clinicians confidently treat them? The history of trigger points in Western medicine dates back centuries, where physicians noted the existence of nodular, painful, and pressure-sensitive areas in tissue, some hypothesizing that they might arise from inflammation and microtrauma. It was not until the 1950s that these observations were formally defined as trigger points, largely due to the work of Travel and Simmons, where they also provided detailed anatomical maps and clinical observations, establishing these points as the primary sources of persistent pain. And just like that, the rest is history. The work of Travel and Simmons was and continues to be influential in shaping the diagnosis and treatment of myofascial pain and myofascial trigger points.
Dr. Travell's pioneering work in myofascial pain has focused increasing international scientific attention on what is now considered one of the major causes of pain and dysfunction.
Seeing widespread adoption among health professionals like physiotherapists, chiropractors, osteopaths, massage therapists, and even dentists and physicians. Their legacy resulted in decades of practice into the nuances of myofascial pain and trigger points. As important as these early ideas were, they lacked the robust scientific evidence that would become essential in later research. For example, in a 1979 study by Lewitt, flaws in the anatomical outlines of trigger point theory already started becoming apparent. In her study on dry needling and trigger point patterns, she stated, "It is obvious that there are many such points and that they have sometimes been chosen arbitrarily, there being no accepted standard," highlighting the need for more robust testing and standardization about their diagnosis. So today we define myofascial trigger points as hyper-irritable spots in skeletal muscle, often manifesting as taut bands or muscle knots, and cause referred pain. But the physiological foundation and reality of trigger points continues to be controversial. The problem is that currently the evidence has become somewhat muddled, similar to the case with dry needling. There's such a plethora of research, it's easy to cherry pick what data aligns with your beliefs, but my intention is to steer clear of that approach. We should comprehensively review the spectrum of evidence and evaluate it objectively to understand the scientific consensus based on the strength, volume, and quality of available research. In the 1990s, data began to show inconsistencies in clinicians' ability to detect trigger points. This is where researchers started looking at what we call the inter-examiner reliability, a measure that assesses the diagnostic agreement among different clinicians, which shows the variability in their conclusions for the same patients. There are so many studies like these which showed some success in clinicians' ability to identify trigger points, especially when they were given a specific diagnosis to work with. This hinted at a certain level of consistency and reliability when it came to clinicians' ability to detect trigger points, which showed that, at least with specific information, clinicians could agree on their presence. However, this perspective was conflicting, as we also have tons of research like these, which shows or paints a different picture. They showed that when clinicians were blinded to a patient's diagnosis, their capacity to reliably identify trigger points significantly diminished. The reason for these disparities becomes apparent when you look at the nature of the studies. When clinicians are blinded to a diagnosis, it helps to ensure that the patient's symptoms, their response to treatment, and the overall assessment are as objective and unbiased as possible. So in situations where they were provided with a specific diagnosis or patient information, their ability to find and agree on trigger points increased. But when this contextual information was removed and they were asked to identify trigger points without any preconceived notions, the reliability of their diagnoses plummeted. This was a crucial revelation as it indicated that the identification of trigger points might be more subjective than previously thought, suggesting that it's influenced by a clinician's expectations or prior knowledge about the patient, rather than being based on pure objective physical examination findings. Systematic reviews and meta-analyses in later years further complicated the narrative, such as these from Tuff and colleagues in 2007 and Lucas and colleagues in 2009. These are research studies that methodologically synthesize all the relevant information on a specific topic and statistically combine their results to offer a consolidated understanding of the data. They basically concluded that our understanding of trigger points, especially regarding their identification and their role in pain syndromes, may be too simplistic. The results again showed poor agreement among practitioners, showing that even experienced clinicians have difficulty identifying the same areas as trigger points, which again makes it unreliable. There is no accepted reference standard for the diagnosis of trigger points, and data on the reliability of physical examination for trigger points is conflicting, according to Lucas et al. It is not yet evident that examiners can agree on the precise location of an active trigger point. Hence, they cannot be relied upon to accurately insert the needle into the nodule of the taut band. This is in the case of dry needling. In essence, this body of research shows a pivotal issue in myofascial pain syndrome theory. The identification of trigger points is heavily contingent on the examination context and the information available to the examiner. It underscores the need for more empirically validated, standardized, and objective methods when it comes to the identification and the understanding of trigger points. So that's where we have to look at more objective clinical investigations like imaging, EMG research, and biochemistry. The identification of trigger points is further complicated by the lack of clear, consistent imaging evidence. Surprisingly enough, I discovered this systematic review by Muzza and colleagues in 2021, which showed a degree of reliability in assessing trigger points only when using ultrasound elastography and Doppler ultrasound. It suggested that the blood flow and biomechanical properties of trigger points, such as stiffness and elasticity, are distinguishable from those in normal tissue. The caveat is that we still cannot confidently say that this data is reliable, due to the limited amount of data and the inherent risk of bias that was noted in the studies. Risk of bias means that a study might contain systematic errors or biases in its design, conduct, or analysis that potentially affects the accuracy and reliability of its results. Simply put, it reflects the probability that flaws rather than actual evidence influence the study's conclusions. At the same time, EMG, biochemical, and MRI studies do not seem to show any reproducible data that we can reliably assess trigger points. In terms of tissue biochemistry, Shaw and colleagues' 2008 paper used microdialysis in a tissue biochemical analysis, measuring things like neurotransmitter activity and inflammatory markers in and around the alleged trigger points and control tissues. And they found elevated inflammatory markers in both symptomatic and muscle control areas of patients. There was a lack of significant biochemical differences between these areas, suggesting that these markers are not exclusive to trigger points, thereby questioning their uniqueness as distinct pathological entities. In terms of EMG research, Simmons and colleagues in 2002 measured EMG activity and reported minor spikes in and around these areas. However, these findings were often indistinct from background noise, casting doubt upon their utility as definitive evidence of trigger point activity. Simmons later recognized that the acceptance of trigger points was limited by two major factors: the lack of a universally accepted diagnostic gold standard and a clear understanding of its pathogenesis. Lastly, there was a very controversial journal article put out by Quintner and colleagues in 2014, which concluded, "We propose that sufficient evidence has been performed to allow trigger point theories to be discarded. The scientific literature shows not only that diagnosis of trigger points is unreliable, but also that treatment directed to the trigger points elicits a response that is indistinguishable from the placebo effect." Shortly after this review was published, it was critiqued and denounced by opposed authors, which accused Quintner's paper of being biased, dishonest, and in poor taste. But the interesting part is that upon doing a quick background check on these authors, I found out that they either sell books or courses relating to trigger point assessment or dry needling, which indicates a potential financial incentive to defend it, and an obvious risk of bias. Very fishy. So by now, if you're questioning the existence of trigger points, you may still be wondering what to do about the annoying freaking sore spot in your mid-back. Consider this. If you press on any sensitized tissue, it is going to hurt. And if you're wondering about the taut bands often mentioned, well, here's my opinion. Our bodies are not simply made up of flat, smooth, consistent tissue. We have ridges, bodily structures, nerves, vessels, muscles stacked on top of each other, tendons, ligaments, and connective tissue intertwined. That bump that you feel is likely not an irregularity within a single muscle, but simply just a bump, a result of the immensely complex architecture of your anatomy. However, it isn't uncommon for normal anatomical structures to be misinterpreted as abnormalities. This is a phenomenon known as pareidolia. Pareidolia is the perception of specific entities from vague stimuli, which could play a huge role in the identification of trigger points. This psychological phenomenon is a common topic of discussion and research amongst radiologists, suggesting that our diagnoses can be influenced by things like previous experiences and biases. Sound familiar? This insight provides a psychological explanation for why clinicians and even patients may misinterpret normal anatomical features as abnormal trigger points. In radiography, areas in interpreting medical imaging such as X-rays, MRIs, and ultrasounds are largely due to failures in perception. The task of medical image interpretation is inherently difficult, with complex displays that vary widely in appearance. This difficulty can lead to certain illusions, contributing to errors. Just think about how these principles of pareidolia and radiography can apply similarly to myofascial pain theory. Both involve subjective interpretation of clinical findings. In radiology, visual illusions can lead to misinterpretation, causing either overdiagnosis or underdiagnosis, while in trigger point assessment, diagnoses primarily rely on palpation, which is subjective and can vary in reliability. Both fields use pattern recognition, again visually in radiology, where certain diagnoses are made based on distinct visual patterns, and tactile in trigger point assessment, where certain responses and symptoms like jump signs, a twitch, or referred pain might lead to the immediate assumption of a trigger point. Both have potential limitations due to technology. Advancements in radiology equipment can assist or hinder diagnostics by introducing new contexts for illusions and perceptual errors. And similarly, for trigger point assessment, although ultrasound is a promising modality, it is more expensive, time-consuming, and not widely available, making palpation the diagnostic gold standard, which yet again is unreliable. In summary, it is crucial to understand that these are subjective interpretations, which are often ingrained early in our education without much questioning. Therapists are taught to embrace these subjective interpretations and incorporate them into their practice, further reinforced by their supervisors and educators without much critical thinking. Treatments based on trigger point theory definitely have an impact, but not for the reasons we often assume. The effects are usually non-specific and provide only temporary pain relief. This is due to transient neuromodulatory effects or mechanisms, which basically means that it temporarily reduces the sensitivity of the nervous system by introducing another stimulus. These effects are combined with contextual factors, the placebo effect, and the self-limiting nature of most musculoskeletal complaints, which often resolve over time on their own. As a result, patient outcomes are usually positive. This positive outcome can create a feedback loop, reinforcing the belief that these treatments are effective. You feel better after treatment because I addressed the supposed trigger point, so we all believe the treatment and diagnosis were correct. But we know this may not be the case. Still, the point of this video was to address the nuance and show you both sides of the story. Our understanding is still evolving. We must lean towards methodologies that are not only scientifically sound, but are also patient-centric, addressing the multifactorial nature of pain. This is not about abandoning old theories, but about adopting a more holistic, evidence-driven approach to injury rehabilitation and pain. One that genuinely addresses the complexities of human beings.